Rajitha Vanga and today's topic is on development of respiratory system. So here is the respiratory tract development. So we can divide this respiratory tract development into two parts, upper respiratory tract and lower respiratory tract. So upper respiratory tract consists of nose, you can see here the nasal cavity, nasopharynx, and also the oropharynx, and that is about the upper respiratory tract. Lower respiratory tract is formed by the larynx, trachea, principal bronchi, and interpulmonary bronchi and lungs. So upper respiratory development usually we discuss along with the pharyngeal arches, face, nasal cavity, which develops along with the face. That is, nasopharynx is derived from the nasal cavity, and pharynx, that is, they are from the nasal cavity, and pharynx, which is from the pharyngeal arches, and oropharynx is from the pharyngeal arches again. So that is about the upper respiratory tract. What is important in today's session is only about the lower respiratory tract. Usually the development of respiratory system, it implies the development of lower respiratory tract, that is the formation of trachea, bronchi, and formation of lung buds, which eventually forms into adult lungs. So the respiratory system is endodermal origin, and it develops from a median diverticulum of foregut called as laryngotracheal groove. So here is the image of pharyngeal arches. Now we can see first, second, and here I am just labeling for you to understand. So this is the thyroglossal diverticulum and duct, which later develops into thyroid gland from the second pharyngeal arch, the third pharyngeal, fourth and fifth pharyngeal arch, and sixth also. Fifth one will disappear. So here is the sagittal section. We can see the development of this respiratory diverticulum, which is from the laryngotracheal groove. So laryngotracheal groove appears in the floor of the pharynx ventral to the foregut, which evaginates to form laryngotracheal or respiratory diverticulum. So laryngotracheal groove appears in the floor of the pharynx ventral wall of the foregut, seen as a midline groove, which evaginates to form the laryngotracheal diverticulum, that is the respiratory diverticulum, during 4th week of intrauterine life. So therefore, the lining epithelium of the larynx, trachea, bronchi and lungs is derived from the endoderm, because it is from the gut tube. So pharynx and larynx, they are all from the gut tube. So that is the reason the whole respiratory tract, that is the larynx, trachea, bronchi and also the lungs, are all derived from the endoderm. The cartilages, muscles and the connective tissue components of respiratory system develop from splanchnic mesoderm surrounding the foregut. So the connective tissue component and the muscle component is derived from the splanchnic mesoderm, which is surrounding the mesoderm. The laryngotracheal groove deepens to form a longitudinal diverticulum called as laryngotracheal groove or respiratory diverticulum. So tracheoesophageal septum is the septum which separates this laryngotracheal groove from ventral portion from esophagus, primitive esophagus, which is present on the dorsal side. So a tracheoesophageal septum divides the foregut into a ventral portion, that is a laryngotracheal tube, which is shown in the blue color here, this one, blue color, and the dorsal portion, that is the primordium of oropharynx and esophagus, which forms the oropharynx and esophagus in adults. So the ventral portion forms the larynx, trachea, lung buds. So you can see the ventral portion eventually growing into two as primary bronchi and lung buds. So the laryngeal cartilages and the muscles are derived from the somatomeric mesoderm of pharyngeal arches of 4th and 6th pharyngeal arches. And thus the laryngeal muscles are innervated by the branches of vagus, that is the superior and recurrent laryngeal nerves, which are the nerves of 4th and 6th pharyngeal arches. The laryngotracheal groove deepens to form a longitudinal diverticulum called as laryngotracheal diverticulum. So we can see here it is a laryngotracheal diverticulum. So the distal part of this diverticulum is separated from the esophagus by a development of a septum, which is called, this dotted line which is shown here, this septum is called as tracheoesophageal septum, whereas its cranial part, it communicates with the pharynx. Cranial part, we can see it communicates with the pharynx. This communication with the pharynx forms the laryngeal inlet, and at the distal part of the laryngotracheal diverticulum, the lung buds develop and divide into two bronchial buds. So we can see it divides into two bronchial buds, and which further branch into primary, secondary and tertiary bronchi. So we can see the development of tracheoesophageal septum. So the cranial part, the septum is deficient, which forms the inlet of larynx, whereas the caudal part, it grows, deepens, separating completely from the laryngotracheal groove from the esophagus, the ventral part. So ventral part further eventually grows into two buds, forming the bronchi and further branching of it. So let's see the development of lung buds now. So here is a beautiful image for understanding. So this is a pharyngeal apparatus where we can see the first pharyngeal arch and all. We can see the developing tongue here, which is growing in the floor of the arches, and we can see the thyroid gland development, thyroglossal duct, which is from the second pharyngeal arch, and we can see this green one, superior parathyroid, inferior parathyroid, thymus, and also the parafollicular cells. All these are from the pharyngeal pouches and arches. So we can see the pouches derivatives, and we can see the esophagus developing here, and this is the tracheoesophageal septum is here. So this is the tracheoesophageal septum, which is groove and separate the esophagus, and the laryngotracheal tube on the anterior side, and we can see the lung bud starts developing. So the tertiary bronchi continue to divide to form a respiratory bronchioles. The epithelium and the glands in the respiratory tube are derived from the endoderm of foregut, whereas the smooth muscles, connective tissue, they are all from the surrounding mesenchyme. The tracheoesophageal septum divides the foregut into a ventral portion, that is the laryngotracheal tube, and dorsal portion, which forms the primordium of esophagus and oropharynx as well. So the ventral portion forms the larynx, trachea and lung bud. The laryngotracheal diverticulum grows downwards to enter the thorax, and where it becomes bifid to form two right and left bronchial, that is lung buds. They form bronchial buds or lung buds. So the part of the diverticulum proximal to the bifurcation forms the larynx and trachea, whereas the bronchial buds form the bronchi and the lung parenchyma. So that is about the lung buds formation. So each lung bud invaginates into the pericardio-peritoneal canals. So we can see here, this is a schematic image for us to understand pericardio-peritoneal canals on each side. This is the pericardial cavity, and this is the foregut. We can see laryngotracheal diverticulum. Eventually it becomes bifid here. When this bifid part grows, it invaginates the pericardio-peritoneal canals. This pericardio-peritoneal canal later gets reflected to form pleura and pleural cavity. So the right and left pericardio-peritoneal canals forms the right and left pleural cavities respectively, and the visceral pleura is derived from the ventral splanchnic mesoderm, that is ventral splanchnic lateral plate mesoderm. So visceral pleura is intimate with the lungs, lung buds, whereas the parietal pleura, the outer one, the parietal pleura is derived from the somatic lateral plate mesoderm. Next, that was about the development of lung and lung buds. Let's see some congenital anomaly associated with it, which is a very common congenital anomaly called as tracheoesophageal fistula. So the faulty partition of the foregut by the tracheoesophageal septum leading to an abnormal communication between the trachea and the esophagus. This anomaly is often associated with the esophageal atresia. So first image we can see a normal image, the esophagus is front and laryngotracheal groove, which is the trachea and the lung buds are on posterior. In second image we can see the esophagus communicates with the trachea forming a fistula here, and where we can see the cranial part of the esophagus undergoes atresia. Here the fistula and atresia and also the communication both proximal and distal parts of esophagus, that is the third variety, atresia with double fistula, and the third one atresia with the proximal fistula. So the distal part is completely atretic, and whereas the proximal one, it persists and continues into the trachea forming an abnormal fistula. And here is the atresia of the esophagus, both the ends proximal and distal are atresia, but there is no fistula here, there is no communication with the respiratory tract, and here the only fistula exists without any atresia. So this is tracheoesophageal fistula. So the various types of tracheoesophageal fistula we have seen. The upper part of the esophagus ends with a blind pouch here. Okay, and the communication forms sometimes a fibrous cord also, and forming atresia of esophagus. Let's see the stages of maturation of lung, how the lung matures. Maturation of the lung occurs in 4 phases. Pseudo-glandular stage, that is period between 5 to 16 weeks. So the term pseudo-glandular means it is because when during the stage the histological appearance of the lung resembles like an developing exocrine gland. So first phase is the pseudo-glandular. Usually it exists between 5 to 16 weeks, and here it appears to be like an exocrine. So the bronchial tree is formed in pseudo-glandular stage and formed by the terminal bronchioles, that is conducting airway up to the terminal bronchioles will develop. Elements of the bronchial tree involved in the respiration, that is the respiratory bronchial alveolar ducts, are not developed in pseudo-glandular stage. Second one is the canalicular stage, which exists between 16 to 26 weeks. So in pseudo-glandular stage, one thing to be noted, the respiration is not possible in this stage. Hence, premature fetuses cannot survive if they are born during this stage. Canalicular stage, which is between 16 to 26 weeks, during this period, the lumen of the terminal bronchioles, they dilate, and therefore a further subdivision of terminal bronchioles into a respiratory bronchiole occurs, and the luminal diameter of the conducting system increases, and respiratory bronchioles, alveolar ducts and terminal sacs, even the primitive alveoli are formed. Respiratory bronchioles and the alveolar ducts are formed, and fewer alveolar sacs are also formed. Lung tissue is well vascularized in this stage. The fetus born at the end of the stage can survive, and which if given intensive care unit. Next, about the third stage, the terminal sac stage, that is 26 weeks till birth. So terminal sac stage, in this period the large number of terminal sacs, that is primitive alveoli develop, and the capillaries are also perforated and form pluxes around the terminal sacs. So the wall epithelium of the terminal sacs becomes very thin and the capillaries bulge in these sacs. So the close intimate contact between the epithelium and the endothelial cells establishes. So the blood-air barrier which permits adequate exchange of gases for survival. So premature infants born during this period can survive with intensive care. Alveolar type 1 and surfactant producing alveolar type 2 cells also develop during terminal sac stage, and their number gradually increases towards the full term. And next stage is the alveolar stage. Alveolar stage is from 8 months to 8 years. In this stage, the terminal sac and the respiratory bronchioles divide and form the alveolar duct. And formation of definitive alveoli with an increase in the number of type 2 pneumocytes, that is type 2 alveolar cells, which produce sufficient amount of surfactant and free exchange of gases across the blood-air barriers forms an epithelium of alveoli and endothelium of capillaries. So the definitive alveoli, mature alveoli do not form until after birth. About 95% of the maturation of alveoli develop after birth only. 95% will be after birth, that is about the alveolar stage. And next about the tracheobronchial tree and the lungs. During 7th to 10th week, we see the formation of tracheobronchial tree and the lungs. So we can see stages of maturation. This is a pseudogangliar stage actually. Fetus with between 7th to 16th week of development, where the respiration is not yet started, but we can see a blind pouches of development along with the blood vessels. So that is about the maturation of lungs. Fetal breathing movements, this is very important. The real-time ultrasonography, they start before birth. Okay, the fetal breathing movements start before birth. So ultrasonography has revealed that the fetal breathing movements, they start before birth and they occur intermittently and exert sufficient force to cause aspiration of amniotic fluid into the lungs. And fetal breathing movements are essential for normal lung development and increase in the time of delivery approaches. And at birth, the lungs are approximately half filled with the fluid, amniotic fluid, which is derived from the amniotic fluid and tracheal glands. And aeration of the lungs at birth rapidly replaces the intraalveolar fluid by air. So that is about fetal breathing movements. Factors essential for the normal lung development. There are three important factors essential for normal lung development: adequate thoracic space to allow the lung growth and fetal breathing movements. Next is adequate volume of the amniotic fluid. So those are the three important. Medico-legal importance to find out whether the newborn infant was born alive or born dead, stillborn. So the lungs of the newborn alive always contain some air within it, hence they float in water and crepitate on pressure. The lungs of a newborn infant born dead, that is the stillborn, are firm and sink when they placed in water because they contain fluid, not air. For this reason, they do not crepitate. So this explains whether the newborn infant is born alive or born dead or stillborn. So let's see some congenital anomalies. Acute respiratory syndrome, acute ARDS, acute respiratory syndrome occurs when the fluid builds up in the tiny elastic air sacs and in the lungs, and this condition is common in premature infants, and most common cause of respiratory distress syndrome is a deficiency of surfactant because of underdevelopment of type 2 alveolar cells. If type 2 alveolar or type 2 pneumocytes, if they fail to develop, this results in acute respiratory distress syndrome. Congenital anomalies with the development of lungs. So agenesis, here is a condition showing the agenesis, unilateral agenesis of the lungs, non-development of the lung. It is a rare condition and occurs if one of the bronchial buds fails to develop. Agenesis of both the lungs is still rare. The unilateral agenesis of the lung is compatible with life, and that is about the here in this image. Next, about the hypoplasia. Hypoplasia of the lung in this condition. So in this condition, the lungs are small and underdeveloped, and it is usually occurs due to congenital diaphragmatic hernia, CDH, congenital diaphragmatic hernia, in which the abdominal contents herniate into the thorax and the lung is unable to develop normally because it gets compressed by the abdominal viscera. So the lung hypoplasia is characterized by markedly reduced lung volume and hypertrophy of smooth muscles of pulmonary arteries. Let's see some more congenital anomalies about the abnormal lobes of lungs with associated anomalies. So here is the image showing the abnormal lung lobes. So the abnormal lobes of the lung, in this condition sometimes the right lung or the left, here it is on the left side we can see. So the lung consists of 2 lobes instead of 3, or the left may consist of 3 lobes instead of 2, and these anomalies occur due to the abnormal division of principal bronchi into lobar bronchi, and they are associated with anomalies of lung fissures, and these anomalies are clinically not clinically significant because the individual would be very normal, even though if they have 2 fissures or 3 fissures abnormally present. So in this image, this is an extralobar sequestered lobe of the left lung, where the arterial supply of the thoracic or the abdominal aorta, we can see directly a branch of abdominal aorta supplying this lobe, extra lobe. So, and the venous return to hemiazygous, we can see the venous is going into the hemiazygous vein, and here is the next image showing an abnormal bronchus, principal bronchus opening directly into the trachea. So it is an extralobar sequestered lobe supplied by accessory bronchus. Intralobar sequestration with cavitation. So we can see intralobar sequestration with cavitation. The third image is with cavitation. So arterial supply from the thoracic, directly from the thoracic or the abdominal aorta, and venous return to the pulmonary veins. Here the venous return is to the pulmonary veins. So these are the 3 images explaining the abnormal lobes and its associated anomalies. So with this, we wind up the development of respiratory system. Thank you.